So is the antibodies cocktail used on Donald Trump, now available in India, a game changer? As big a game changer as it's being talked about? Let's understand this in detail. First, what is the antibodies cocktail or monoclonal antibodies as they are called? Well, these are laboratory-produced antibodies designed to recognize and bind to the specific sites on the given protein. This could be the spike protein, say for SARS-CoV-2 that we're talking about right now, or receptor protein found in the surface of the cell. Now, unlike the natural antibodies that are polyclonal, this is actually a mixture of antibodies that recognize different sites on these proteins, and then the monoclonal antibodies are more specific, and that's the key here, and often bind with higher affinity. This allows them to better recognize and fight the foreign invaders such as bacteria and viruses, so it can be used for several other things as well, not just COVID-19. Effectively, these are antibodies that are created in a lab and tailor-made to fight this virus. So how does it work? Now these, like I said, they bind with the spike protein to prevent the virus from attaching to the human cells and then target for their destruction as well. The COVID-19 diagram that you see with several spikes on its surface, well, that actually helps the virus attach and enter the human cells. Several monoclonal antibodies have been developed to bind with those spikes of COVID-19 and block the virus from invading the human cell. Patients with COVID-19 may receive them with an IV infusion. Usually it can be given in an emergency department. There are infusion centers as well. So that means you don't really need to be in a hospital. You can get this even outside the premises of the hospital. But the key question here, who needs it? Well, of course, people who have COVID-19 need it, but only these are effective if given in the first 7 days of the infection itself, to basically nip the infection in the bud. So this treatment does not prevent you from the disease or the infection, but will prevent you from severeness of the disease and thus prevent you from death as well. That way, it's similar to say what a plasma therapy was like, except that while plasma is a mixture of many low and high affinity antibodies, this is a highly categorized product of high affinity and effectiveness. So the question is, can anybody really take these antibodies cocktail? Well, early data suggests that greater benefit is only for high-risk patients or those with comorbidities or those with suppressed or weak immune system, meaning those people who are older than 65 years of age or have medical conditions like have had transplants in the past, or are cancer patients with weak lungs, or those who are clinically obese as well. Also, it's for positive cases who are not sick enough to be in the hospital, but who have some risk factors for severe infection. Remember, the first patient who actually got this treatment was an 82-year man with multiple comorbidities. But there are also those who are advised against this treatment. The FDA, for example, says they do not authorize this for patients who require oxygen therapy due to COVID-19 or those who are already dependent on oxygen or artificial oxygen supply due to an underlying non-COVID related comorbidity, and thus require COVID-19 in the situation of COVID-19 an oxygen flow rate that is either higher from the baseline. Efficacy, how effective is this? What is the effectiveness of this treatment altogether? Well, that really depends on what cocktail you get. Like different vaccines have different efficacies, well, this also, in this case, different combinations and different cocktails will have different effectiveness. What we have as data is that a combination of casirivimab and emdevimab has 70% effectiveness. The combination of bamlanivimab and etesevimab has 70% effectiveness, and then really the king over here is the sotorasvimab, which has 85% efficacy, as is being talked about. And then the question is all about availability. That's the reason why in India people are getting so excited about this therapy. Cipla and Roche have now launched these antibody cocktails in India. The first successful treatment was actually done in Medanta Hospital in Gurugram, and now Fortis Hospital has started the treatments as well. And then the million-dollar question of the cost. Well, the cost also differs from cocktail to cocktail, but it mostly will range between 60,000 to 1 lakh rupees, depending on how many doses you actually go on and get. All right, so that is all you really needed to know about what exactly is this antibody cocktail all about. But to take this a little further, we've got with us a dream team really. We've got Dr. Shahid Jamil with us on the program. Very good to have you back. We've got Dr. Sumit Ray back on popular demand on the program. We've got Pinto also, Dr. Pinto back with us on the program as well. And we've got Dr. Pushpak joining us, Dr. Pushpak Gupta joining us from the and he's also a member of the Royal Society of Medicine in London. He joins us from UK. Thank you all for your time. I want to give the first word to Dr. Shahid Jamil over here. Lots of questions regarding this. I simply want to understand from you, is this as big a game changer as it is being talked about?
Well, it's certainly another tool in the fight against COVID, Sonam. Remember, we don't have any specific medicines for COVID. Doctors have been doing a wonderful job treating people for symptoms, treating people for inflammation that happens in the lungs. But about the only medicine we have is your good old paracetamol to take down fever and steroids to reduce inflammation. So this is really the first time that we have something that is directly efficacious against the virus. Remember, everything else, whether it's Faviflu, Favipravir, or this other medicine, they were not designed for COVID, for this virus. They were designed for other viruses, and they work with variable efficacy. In large trials, they have really not shown too much benefit. So I think this is the first time that we have something very specific. And if this technology really works very well, then there's a lot of potential, because even in India now we have the ability to make humanized monoclonal antibodies against different viruses, so I think, yes, this is a testing ground. It will be a game changer for many other things that are bound to come in the future.
Okay, so go ahead from Dr. Jamil over there. Let me bring in Dr. Sumit Ray over here. The million-dollar question, how will it work against the variants?
Couple of things before we go to the variant, Sonal. In a sense, it is an important tool that we have now. Having said that, we have to realize that this is to be given early in the course of disease when the disease is very mild. So selection of patients, like anything in medicine, and particularly in diseases which kill, the selection of patients is important. Everybody doesn't need it. The reason being 90% of us will have mild disease. Okay, so it is only those who have potential to have serious disease, illness, as you said, are the ones who need it. So everybody should not be rushing to get it for 3 reasons. One is that if you have a mild disease and don't, you have no, the chances of your having a bad kind of disease is less than if you take it. 2-3 potential disadvantages that are there. One is something called dependent, increase in enhancement of disease. So what happens is, if you take this antibody, you actually may have a worsening of the disease. So there is a potential for that for all antibodies. So one has to realize that no drug is without its side effects. Okay, and not just basic side effects, but serious side effects. So there can be an enhancement of disease also, because our immune response is a very complex phenomenon, right? We have to remember that. Second is that the possibility, if you use it in large volumes in too many patients who really don't need it, then you may actually push for more variants being promoted, right? Third is obviously the cost. I mean, really, do we need, I mean, we have to be very, very selective for any treatment, even for steroids. Steroids is not a treatment for mild COVID. Steroids is only the subset of patients who require oxygen or have severe illness, they require steroids. So there is a subgroup or a subset of patients for every, every disease, and within COVID also, which are the one patients who require, where monoclonal antibodies can help. So these are the things we have to think of before we say that this works or does not work. Yes, it works. It works in a subset, but it has its side effects and it has its potential problems going forward also by making more variants. Now the third, now answering your question, that will it work against variants? Well, different cocktails are working, are seen to be working with different variants, but going forward, if the virus mutates, will it or will it not, depending on the significance of the variant. I mean, how much the variant has shifted from its original version, and that question probably Dr. Jamil will answer better than me about how much the shift is, and depending on that, these antibody cocktails may or may not work.
Well, lot to unpack from what Dr. Ray has just said, but I'll come to those bits. I wanted to ask about fears of mutation formation as well, but I'll come to that in just a bit. Let me take the opening comments from Dr. Pinto as well.
So I would just like to add to what Dr. Ray just said. If you look at the actual study, which is now in a preprint version, there were about 3% of individuals who either had hospitalization or death versus 1% of individuals in the group that received the cocktail. So this 70% is coming from a difference of 3% to 1%. When you look at an absolute difference, it's a 2% difference. It's not, so 70% is what we call the relative risk reduction.
Right.
If you look at the number of deaths actually in this study, the probability of death or the number of deaths were something like 2 in 1,000 in the group that received the group, and less than 1 in 1,000 in the group in the group that received the cocktail. So the probability of death was extremely low, and this was not statistically significant. So we should be a little careful in calling these life-saving medications, because I don't think the life-saving part is proven beyond a reasonable doubt yet. But of course, it does seem to lower the viral load. That's clearly shown in the studies. It does seem to shorten the duration of illness, which is very promising. It lowers the probability of hospitalization, which is great. But I think it's extremely important to make sure that this doesn't go down the route of all the other medications, where people on oxygen, people on ventilators start these SOS calls to receive this because of this word life-saving that has been thrown around. I think we need to be very cautious that it doesn't go. In fact, one of the studies, which was the Eli Lilly study, which was done with an antibody cocktail, was terminated prematurely because it did not show a benefit in hospitalized patients. This particular cocktail, which is now available in India, has also been tested in the recovery trial. From what I've heard, it's a negative study, not been published yet, but it doesn't seem to act in patients who are admitted already to a hospital. So the bottom line is, if you are sick enough to already be in a hospital, this is not for you. And I think that message needs to be a lot more louder than where it really works, because that's where we floundered in the past, over the past year.
Right. We've learned our lessons, hopefully, from what happened with remdesivir, what happened with plasma therapy. And now, so every time a new treatment comes in, I understand why doctors are so cautious and trying to get that word out first up before they even start discussing this. So that's good to be put on the table. Let me bring in Dr. Gupta now. Dr. Gupta, your thoughts on how it is being used. India is quite new to this. We've just had one patient come out and get discharged after the use of this therapy, but what has been response been internationally?
Yeah, thank you for having me on the show. I think, as you said, India is very new to this. However, I've been involved with the recovery trial in the last few months, and this was one of the drugs that was being studied in the recovery trial. We have now published findings from tocilizumab, and tocilizumab is a type of monoclonal antibody which is now in the protocols in the United Kingdom to be used in patients that are hospitalized. So I'd like to defer with Dr. Pinto just a little bit there, but I think we're using it at the moment. We've seen some benefits. I don't think that it is, as he said, a life-saving wonder drug. I think monoclonal antibodies have been used for years in conditions such as rheumatoid arthritis and various other diseases to either block a process or to enhance a process. And in COVID, the importance of monoclonal antibodies comes in trying to prevent that intense inflammatory cytokine storm that happens within the lungs that sort of destroys even the lung parenchyma. And so IL-6 inhibitor, as it is known, it's a type of cytokine which it inhibits, and that causes a reduction in that inflammatory damage that is caused to the lungs. So we've seen some use of it, but we've mostly seen it used in patients that are hospitalized, that have been on dexamethasone, that have inflammatory markers like CRP that are raised, and that have findings on the radiodiagnosis that show that they are positively COVID-19. And the purpose of using it is to try and prevent them to reach a point where they need mechanical ventilation. The purpose of it is not to be, per se, sort of curing them or treating them of COVID-19. It's to try to prevent the progression of disease from the point that they probably don't need ICU admissions. And I think it has worked quite well in the UK. We're not using it like candy, though. We're using it very, very specific patients, and it is only being used in a hospitalized setting. So I'd like to differ a little bit with what you said at the start, where it can be used at home. I would highly advise against that. It should be used within a hospital setting, in a complete control setting with doctors around to monitor any side reactions.
All right, Dr. Ray wants to come in.
Yeah, I think there is a bit of a confusion. I think that we are talking of two different sets of drugs. Dr. Gupta, I think we were talking about the antibody cocktails against the virus at the early stages, not the tocilizumab, which is the anti-inflammatory anti-IL-6 cocktail. So I think the program was about that. So tocilizumab, absolutely agree with you that it should be used in the hospital. That's a completely different role. It is almost used post-viremia. Actually, the post-viremia inflammation is what you suppress. So there's two different sets of drugs we are talking about, I think. So I think we should separate these two sets of drugs.
Okay, good to have the clarification. Let me go to Dr. Jameel at this point. Dr. Jameel, so what I'm hearing from the panel at this point is that it is to be used only in the high-risk patients, people who have comorbidities. It is to be used in the first 7 days of the infection. It is not for everyone. And then there is the cost behind all of this. So I'm assuming at a cost of at least ₹1 lakh that you need for multiple doses, it can only be used by the rich and by the privileged in the country.
Well, that's true. The cost is there. And just like Dr. Sumit and Dr. Pinto said earlier, these sets of antibodies, the one from Roche, the one from Eli Lilly, or the one from GSK that we're talking about today, are antiviral molecules. These are antibodies that bind to the surface of the virus and prevent the virus from entering cells. Now, the logic of using this early is that you use it early to prevent virus entry into cells so that the virus doesn't get a chance to get into cells and multiply to very large numbers. Once the virus is multiplied and once our own immune response starts reacting to the virus in a way that it kicks something called a cytokine storm, then these antibodies become useless. Then what is useful is what Dr. Gupta was talking about, tocilizumab or itolizumab, although the efficacy there is a little doubtful, which control inflammation. So these are very different molecules we're talking about here. Now, let me address the question of viral variants. It's good that that question was asked. Already we have data from the Eli Lilly antibody combination, and also I think from the Roche Cipla combination, that if there is a mutation which is called E484K or the EEK mutation, these antibodies don't bind as well to the virus as they would bind otherwise. Okay. Also, if there is another mutation which is called L452K, there is a modest reduction in the efficacy of these antibodies. So coming to the Indian situation, if you remember, India has this variant which is now called B17617.
Delta now.
Yeah, which everyone initially called the double mutant, which was a misnomer. I don't want to call it the Indian variant. It's not the Indian variant. Let's just call it B617. And the new nomenclature, the WHO is now proposing calling it the Delta variant. So this variant has the L452 mutation, which reduces the effect modestly. It also has a mutation which is similar to E484K. It is called E484Q. Now, we don't know what the effect of that mutation is on these antibodies. So I think we should understand that some targeted mutations will reduce the binding and the efficacy of these antibodies. But when a patient is admitted, there isn't enough time possibly to sequence the virus and to know what variant is there. So the efficacy is reduced, but it's not gone completely. So this is something that should be understood. Coming back to the other point, I think these are the kinds of drugs which hold a lot of promise. And as I said earlier, in India, we now have several groups, academic groups, that have the ability to make these antibodies. And the way you make these antibodies is take the blood from a person who has been infected and has recovered. You isolate the antibody producing cells from these people, and then you enlarge that in culture, and you produce these antibodies through genetic engineering means. So it is possible to do that. And with Indian pharma and Indian vaccine companies, I think this is something we can upgrade it. By the way, it's not yet known generally, but there is an Indian group that has produced about 200 such monoclonal antibodies, which have been tested, and some of those show very high affinity. So hopefully, even for COVID, some of those will be taken forward.
So I see there is potential. If I could sum that up, you're saying there is potential in this, and even though at the moment the current cocktails available might or might not work to different intensities against the variants, there is potential that this treatment can be useful in the future as well. But again, with all the caveats that we've mentioned about the kind of people. Very quickly before I go into a break, and Dr. Jamil has to leave us after that, so I just want to ask you, this fear of mutation formation and new mutations actually coming out because of this treatment, how real is that, and how should we be looking at that aspect?
Sorry, is that a
Dr.
question
Jamil,
for me?
Yeah, for you.
Oh, I'm so sorry. Yes, see, mutation is a random process. But the selection of that mutation depends on the selection pressure that you give. Now, if you give high enough concentrations of these antibodies so that they neutralize much of the virus that is present, then the danger of mutation reduces. But if you give suboptimal amounts so that some virus escapes, then you amplify the chances of selecting mutant viruses. It's not any different from antibiotics. If your doctor prescribes antibiotics for 5 days and you start feeling good the second day and stop your antibiotics, you increase the chance of antimicrobial resistance developing. It's exactly the same here. So make sure that enough antibody is given to neutralize most of the virus. If you give suboptimal amounts, there is always the danger of driving more mutations.
All right, good to have that settled. Thank you so much, Dr. Jamil, for joining us. The rest of you will stay with us on the other side of this very quick break. Welcome back. We are discussing antibodies cocktail. It sounds quite fascinating. It's being used in very few places as well. But the verdict here from the doctors seemed to be that it has to be used with caution, as with any other treatment, really. Dr. Pinto, your thoughts, closing comments.
Option in the armamentarium that we have against COVID-19. I think selecting the right patients is important. So if you are high risk, if you are elderly, if you have diabetes, if you have obesity, immunosuppressive conditions such as chronic liver disease, chronic kidney disease, or some sort of malignancies that cause you to be immunosuppressed, you are the ideal candidate for this cocktail. However, the caveats as the study did was that you need to receive it within 72 hours of your RT-PCR and within 7 days of the onset of symptoms. That's where it works.
I'm hearing you, and we've discussed that. But what I want to understand is that how do we learn our lessons from what happened with remdesivir, what happened with the plasma therapy? And Dr. Ray, if you could come in at this point and tell us, how do we ensure that this doesn't go down that path? At the end of the day, this is available in private hospitals. So those who, I mean, we don't want another black fungus sort of situation, right? Overuse of steroids, etc. So how do we ensure this does not happen in the case of this treatment?
The first and foremost is not to promote it as a life-saving drug, as Dr. Pinto said. The second is that some degree of control in terms of who gets that medicine, in terms of having a paperwork to do and having some checks and balances to see who is getting that drug. It should not be used for more profit making than actual healthcare benefits.
So who
That's
will do
where
that?
the check. So it has to be at multiple levels. It has to be at multiple levels. I think the government itself needs to keep a check on it. Whenever they're, I mean, like the amphotericin is being distributed through government channels now because there is a shortage. I think there needs to be a check on distribution of these drugs, where it goes, who gets it, and why they get it. Those questions have to be asked before prescribing to a patient.
Right.
And it should not be it should not be promoted that we are a center which gives this and cures COVID. Okay. I mean, that is the whole promotional structure of certain kind of corporate hospital setups, and that has to be questioned.
Right.
So and also, I mean, as we are discussing from the beginning, is that every therapy has its subgroup of patients it may or may not benefit. It does not benefit everyone. And as soon as you say it is a cure, so if we use the word cure, then it becomes, I mean, people start believing that it can be used on anybody, that anybody who is sick can get it.
Right. Okay, thanks for clarifying all of that. Thank you all so much for your time as well. I'm really out of time. Would have loved to get a comment from Dr. Gupta as well, but maybe in the next program. That's it on today's program. We'll see you again tomorrow.